Welcome to our session today, co-sponsored by the Wellness Committee and the Ethics Committee on moral injury, specific to the context of emergency medicine. We are going to talk about what it is and how it differs from some of the other types of work-related stress that we have. We are going to talk about some of the things that trigger and maybe even try to get some interactive things. And then we're going to talk about what we can do to try to mitigate it. So the mandatory disclaimer slide. And then we have a pretty big panel today. This is a big topic and we wanted to highlight different aspects of it and different ways that people are working in this space. So I'm Cindy Bitter from St. Louis University. We also have Vytas, Karalius, Eric Isaacs, Amanda Ritchie, Taylor Stavely, Stephanie. I know, and I messed it up in our pre-meeting, so I did it right today. Amanda Deutsch and Alvarez. So welcome to our panel. So part of the reason we took this topic on is because every single day in the lay press, you see another article about healthcare, about nurses quitting, about stress. Jay Baruch had a piece that came out yesterday about why we're approaching the issue of moral injury and burnout wrong for the specialty. 1/3 of our nurses, almost 1 million nurses in the US plan to quit in the next 5 years. Physicians are not immune to that. So we have to think about what we're doing well and how we can be more resilient in the workplace, but we also have to address some of these root factors head on. There are lots of ways of talking about the stresses that we face in the workplace. And these definitions have kind of shifted over time, and I like to think of them as a Venn diagram where some of them overlap and a lot of them don't. But with these multiple terms that we use to describe the workplace stresses that we have, there are more ways to talk about it than there are proven strategies to address it. So this needs to be a major research agenda. So burnout, we all have our sort of personal definition of burnout. The original definition was in the 1970s, and it was, at that time, very specifically occupational. Over the years, it's kind of shifted, and we talk about parental burnout, and we talk about caregiver burnout in like personal roles or sandwich generation. But the most recent ICD-10, again, or 11, again, made the point that this is specifically a workplace problem. Emergency medicine has one of the highest rates of burnout, but oddly enough, we also have a relatively high rate of career satisfaction. And I believe that comes down to that last piece, the reduced professional efficacy. I believe that emergency medicines are frequently satisfied because they believe they're doing the right thing and they believe they're taking care of their patients. And that mitigates a lot of the exhaustion and emotional exhaustion. And hopefully some of our black humor is working on that distance and cynicism for the criteria too. Again, PTSD, the term has been around a long time, but coming up on, 10 years ago now, PTSD used to have to be about your own personal experience. 10 years ago, the DSM-3, the psychiatric manual, added indirect exposure, as in taking care of patients, volunteering, taking care of sexual assault victims, taking care of victims of violence, as a criteria to get you into that diagnostic pathway for PTSD. And that's where some of the older terminology of vicarious trauma or secondary traumatic stress syndrome has really gone out the window because we are now classifying that as PTSD. And then we realized that PTSD doesn't completely capture the experience of emergency providers because PTSD implies that there was a single event. And while many of us do face a coup de grace that triggers our mental health symptoms, it's frequently the death by 1,000 cuts. It's the daily stressors. And complex PTSD is meant to address the fact that people have long-term exposure. But when I talk to my colleagues and the mental health professionals, their opinion is that treating complex PTSD is different from treating PTSD, not only because of the potentially ongoing exposures or long-term exposures, but because people have internalized a sense of guilt, a sense of difficulty regulating their emotions that comes from being in that situation for such a long time. And that's really how the mental health professionals think of the difference between complex PTSD and regular PTSD. And then we come to moral injury. And this is one of my favorite definitions. There's a lot of definitions out there, as there are for all of these things. But the key component to moral injury is that our standards, our personal beliefs of how we are supposed to live out our calling and our profession are being violated. So people sometimes talk about moral distress, or they conflate moral injury to people that are being put in situations where they're not sure what the right thing to do. But I believe that you can have some post-traumatic growth by being put in a situation where you are forced to confront your beliefs about what you think the right thing is, whereas moral injury is a very different thing, specifically because we know we are not doing right by our patients, and that harms us in our professional identity. So moral injury is what we're going to talk about today, and those are the definitions. We're going to move on to triggers.
Hi there, I'm Vytas from Stanford, and as part of this panel discussion, I think we want to have kind of an open forum to talk about moral injury in a safe space. So we wanted to have a little bit of an interactive component, so if you guys wouldn't mind pulling out your cell phones and just going to polleverywhere.com/moral injury, or I think you can also text SAEM moral injury to 22333. That would be great. And that's SAEM moral injury. So we kind of talked about the formal definition, but I'd love to just have an open discussion here about kind of how would you guys define moral injury in your every day-to-day context? And you can just free respond whatever you like. Got the trail. Did it freeze? Oh. Good. Choosing from bad choices. When you feel like you're choosing between two bad decisions, violation, distress, good, defeat. So I guess that stems probably into this next question, which is how does moral injury make us feel? Like what emotions come to mind when we find this in the workplace? When we're on a rough shift and we feel like we've experienced or encountered something that's causing a moral injury. Hopeless, defeated, disappointed, hopelessness, exhausted, confused, angry, shameful, shame, sadness, shamed. There's a lot of shame, frustration, exhausting, hopeless. And just out of curiosity, how often do you feel like you experience moral injury in your day-to-day work? Okay. Got it. Often, about 57% say often. They're experiencing moral injury in their day-to-day work. So this is something that we're all experiencing in the room. 12% say always. 28% say sometimes. And then what would you say are some common triggers? What are things that you feel like are a trigger in the workplace for moral injury, where you feel like you're making a choice that's against kind of your moral or ethical or spiritual code that you've kind of promised to in the workplace? What are some things that you find are triggers for that? Your boss, it's good that this is anonymous. Lack of support, hallway patients, yeah. No social work resources, boarding patients, lack of staff, the system, lack of staff again, workplace violence, minimal supplies or shortages of supplies, no PPE, that one's close to home over the last several years, disparities in health, waiting room medicine, yeah, chair care. We've all had to do that uncomfortable history in the chair while there's patients to their left and to their right. Private exams and hallway beds, social determinants of health, inpatient boarding. Sounds like things that we can all resonate with as EM providers. Racism, toxicity, sick patients in chairs for days, having to work while sick. Yeah. And then lastly, I just want to see, like, who do you talk to, if anyone, when you experience moral injury? Or nobody? Colleagues? Spouse? Partner? Co-residents? Friends? Leadership? BF? Boyfriend? BFF? Best friend? Forever? Church? So spiritual outlets? Joking? Sure. Partner? Great. So obviously this is something that we're all experiencing. So I will pass it off to treatment, and we can kind of talk about possibly how we can help in the healing process together. First we're going to talk about policy in hospital systems. The other mic.
All right, hi everybody. We're going to kind of tag team things here with myself. I'm Eric Isaacs from San Francisco General Hospital and UCSF. And Amanda, why don't you introduce yourself?
Hey, I'm Amanda Ritchie. I'm a second-year EMIM at LSU in New Orleans.
So this actually was a phenomenal exercise and experience to be able to hear each other and to learn about the triggers that we are all experiencing, or that you are experiencing, and we are going to run through a few specific triggers to highlight many of the things that you said. And this exercise that Vytas just kind of led us through actually highlighted an experience that I had working with Amanda. Amanda's a resident. I am, not surprisingly, an attending who's been around for a little bit. And, and what I learned from talking with her as we were preparing this is that, no surprise, we have totally different perspectives. The same triggers, but totally different perspectives on what is causing us moral injury. So I thought that I would just run through some of the things that I think we have all experienced, and then hear a little bit about personal experiences, and then kind of lead us through some treatment. So, not surprisingly, I think we are all experiencing boarding and ED overcrowding, and one of the great contributors to this is exit block. I mean, we can't get the patients out of the ED, right? And so why is that? it may be the lack of beds upstairs. It may be the lack of community resources. My cynical view is that it is, services upstairs, I'm not going to call it any names, who round and round and round and round, and then at 3:30 in the afternoon finally get to discharging the patients while they're continuing to build up as we're getting busier in the emergency department. The other is, and I was talking with kind of an old friend from residency in the hallway who brought this up spontaneously, and I think for many of us that work at academic medical centers, we see this, is the sort of economic misalignment that the hospital administration has of prioritizing the high margin patients, i.e. surgeries, with the less profitable patients that come in through the emergency department, and thinking that the money that they collect from the surgeries will pay for everything else. And one of the things that I want to highlight is that there was a study done, and I'm sorry that I'm UCSF centric, UCSF and another center, it might have been in Boston, looked at inpatient mortality. And they found that the kind of baseline inpatient mortality is around 2.6%. But when the ED was overcrowded, inpatient mortality went up to 5.4%. So you have a doubling of inpatient mortality when the emergency department was overcrowded. And so I think it really has greater effects upstairs, and as we will talk about, it's a hospital problem. This was one of the things that I thought illustrated our conflict, but I'm actually going to move ahead just in the interest of time. And I wanted to have Amanda you talk to us a little bit, because Amanda has an interesting background. She does, no. So Amanda.
I don't round that
Yeah,
long,
so Amanda, if I can disclose, prior to going to medical school was an ICU nurse. And now is a trainee. And I'm wondering if you can tell us how your background influences and current position influences your view of what's triggering us and moral distress and moral injury that you're experiencing.
Yeah, absolutely. So as you said, I was a ICU nurse before med school, and I'm Canadian. So when we, Canadians represent, thank you. So when we started having, a lot more of a boarding issue in New Orleans, when patients are waiting 6 hours, 7 hours, 8 hours, I'm like, what's your point? That is standard in Canada. Where I'm from, that's like the base minimum that you're going to wait before you see the doc. Even if you're triaged pretty high, we don't have any beds. We've always had a boarding crisis. We have no room. 8 hours is not that bad. Like, you're fine. There was a running joke for a while that you could bust your knee, fly to Spain, get it fixed, fly back before you'd actually see a Canadian ortho, okay? Even waiting in the ER. So the downside to all that, as funny as that kind of joke is that we've had people die in our waiting room because we don't have any beds to bring them back to, right? Or, we have ICU patients that are boarding in the ER, and the ER nurses are doing their best, but there is so much stuff that they need to do, so many patients they need to take care of, that when they would give me a report as the ICU nurse, I'm like, okay, well, what's their fluid balance? You've had them for like 14 hours. Like, are they positive? Are they negative? Like, what's going on? They're like, well, we don't know. Okay, this patient is a heart failure patient. It's kind of important. I need to know this. Until I take a step back, and I'm like, well, they did their best, right? You can't ask for more than someone is able to give. Even though that's a boarding patient, even though they are critical care trained, the priorities are so different. So then fast forward to being in residency, with all of our boarding issues, the expectation that we really have is that I flex up. If like a portion of my pod is boarding, that I flex up and do some waiting room medicine. So my concern with that is, so I'm second year EMIM. So I do 6 months on each side. I'm really at almost a year on the EM side. So, I'm trying to still set my foundation, make sure I'm covering all my bases, taking care of patients appropriately, picking up the speed, because let's face it, I'm IM, I like to think a lot. And so, kind of reinvent that wheel, train my brain. How do I learn how to flex up How do I learn how to be flexible while still taking appropriate care of the patients that I'm seeing in the waiting room? As I'm scrolling through the entire list, making sure that I'm not missing someone who's super sick, because there's always one who got triaged as a level 4 who's actually like just gonna pre-code out there anytime soon, right? There's always one. So you're trying to find them. How do I juggle my time to still take care of the patients that I'm looking after in the pod? So as a resident, it's really difficult, and it is hard to make sure that I'm doing my best for all of my patients while realizing that I have to be patient with myself because I'm still setting my foundation. I'm still learning. So.
Which I didn't really think about. I, of course, being self-centered as an attending, felt like I can't stand being up in triage and working up there, and think it feels like a waste of my time. But I did. One of our colleagues, who I don't think is here, said, being in emergency medicine is like a fellowship in getting shit done, and we sort of do whatever it takes to get stuff done, and there's this, and he brought up the fact that there was this conflict between you're wanting to lay your foundation for learning emergency medicine, and yet many of our graduates in the community are doing waiting room medicine and community medicine. And so, in a way, it's like there may be learning there, but it's just so painful. I also wanted to have you talk a little bit about the moral adjustment experiences as well, about how flow changed in the ED, and how patients, you were telling me about kind of where patients are walking back to their beds, and just share a little bit about that, because I share the same experience.
Yeah, so, our ER did a huge kind of flip. We changed our layout so that our rapid treatment area was moved into Pod 2, which our waiting room doors open pretty much directly into Pod 2. So during the day, you see like hustle and bustle, tons of patients moving, the NPs and PAs are like circling around all the time. Looks great until you realize that closes at night, and then the doors open to a lights off empty pod, and that's the first thing all the patients see. So they're really not happy when they walk over to either Pod 1 or Pod 3, and they're like, we've been waiting for 14 hours, and that's closed. And we're like, oh, yeah, sorry, it wasn't my choice. And so, that change in flow, initially, it seems like a great idea. I don't know if it was really focus grouped really well about how well it would work kind of at night. But yeah, so it was a revamp. During the day, it works great. But at night, how do we utilize that space? How do we change up our flow so that patients understand that we're not seeing them because we, don't want to? We're not seeing them because we're actually busy in multiple other pods that they don't actually see.
Which, this along with some of the other things illustrated here, reminds me of the saying, death by 1,000 paper cuts, or as someone else kind of talked to me, it's like being in a hailstorm. Like each little piece of hail doesn't really hurt, but dang it, after hundreds and more pieces of hail hitting you, it hurts quite a bit. I just wanted to highlight some of the other things, the emotional trauma that we have experienced, particularly through COVID, where we had no visitors in the emergency department, and we have patients with dementia or non-English speaking patients who have no visitors, nobody to advocate for them, I think has been hurting us as well. Deaths in the ED without their family nearby. Not that it's new, the fact that you don't pee and you don't eat during your busy shifts, but that is one more thing that adds on, I think, to the emotional trauma that we're experiencing. And I know that my own admit versus discharge decisions have changed when I'm willing to take a few more risks when I can't get patients upstairs, and I'm like, I'm just going to get them out of the ED. We wanted to move on a little bit to some solutions, and my feeling is that you can read about all kinds of strategies. Stony Brook started things 13 or 14 years ago, and all these strategies are great ideas, but they are not going to work unless you have sort of 4 fundamental factors. One is that the executives at your institution need to make this a top priority, need to make sure that they know that it's a hospital problem, and that you have hospital-wide coordination of efforts with multiple departments, multidisciplinary nursing, doctors, PT, techs, everybody involved. That that we need to start collecting data related to moral injury. I'm not sure exactly how to do that yet, but that we're also disseminating data or updates related to moral injury. And I heard another example, and one of these people is in the room, chairs of departments or leaders in the hospital who can send out regular updates to sort of increase their transparency about what we're trying to do. It has the potential for increasing triggers when you see what the boarding rate is every single day. But every week, if your leader says, hey, this is what we've been working on, this is what's happening in the community, this is what's happening in the hospital, this is what I'm working on, so that you don't feel totally abandoned. So it does require some communication skills from your leadership. In terms of things that have been tried, we talked a bit about, our ED actually has almost tripled in size. And yet we have filled every single one of those beds and continue to board. So if you build it, they will come. And that is not really the solution. Other things like increasing ED or emergency department staffing decreases the length of stay in the emergency department, but it doesn't change many other things. Let me just revamp my notes here. ED obs units have been successful. They decrease ED length of stay, they decrease hospital length of stay, they decrease the number of avoidable admissions. But at least at my county hospital, we don't have room for an obs unit. I can't even get one there. And I think you mentioned that where you are, you don't have an obs unit either? Yeah. I mentioned, I had a slide about ambulance diversion before. Ambulance diversion has not really had much of an effect, but we do know that when they suspend diversion, there seem to be more injuries in the emergency department. Similar with ICU beds, it does decrease, increasing ICU beds decreases the length of stay in ICUs, but it doesn't decrease overall length of stay. The last slide that I had was what we can do. And I also recognized afterwards, after I submitted these, that my balding, gray, bearded, white face allows me to have greater privilege to be disruptive and call attention to kind of the practical and ethical consequences. But I think if we form, and we're going to talk more about this as community, if we form community, it may protect those who may be marginalized and at greater risk than I might be. Making sure that leaders recognize this as a hospital problem. And then I think we need to start disrupting our organizations or having our organizations advocate for us because I think we're all experiencing these issues. The only danger of this, sorry to end on a negative point, is that we may be pitting our arguments against each other. For example, I worry that the Emergency Nurses Association may have different interests or different advocacy points than we do. I think we are one big team, but there is that danger. So I think we just be aware of that as we continue to advocate. Okay, I'm going to make time for everybody else, hopefully. Thank you very much.
Hi, I'm Taylor Stavely. I'm faculty at Emory.
I'm Stephanie Balint. I'm actually an M3 medical student from Quinnipiac in Connecticut and from the Rams board.
Today we have the privilege of talking about reproductive justice and advocacy. And interestingly, I didn't really see that reflected in the poll today. But I don't think I'm totally off base in thinking that many of you in this room see the changing legislature on access to reproductive care as a source of moral injury. Yes. So while it didn't come up in the poll everywhere, I still think it'll be worthwhile for the next few minutes of your time. First, I have to start with a disclaimer. Isn't that a bummer? This talk that I'm about to give is purely for educational reasons. It's not for legal or medical advice. And this disclaimer was put in at the urging of the legal counsel that I needed in order to give this talk. And the irony of talking about moral injury and the fact that I needed to seek legal counsel to give this talk is not lost on me. I also think it's important for you to know that I had to change my content, and there are things omitted from this talk due to the geographic location of where we're currently sitting. The day that things changed, June 24th, 2022. Who remembers like that day and feeling that day? I do. I felt like physically sick, like physically ill. And as my emotions, kind of changed and evolved after this day, it's something that I now sort of recognize as it was moral injury, and something that started that day and continues to this day as things continue to change. So as a solution, again, this talk, we want to talk about some solutions. What is the solution for you to help overcome or combat that moral injury that you are feeling as it relates to reproductive justice and access to reproductive care? And so I'm going to speak a little bit about the individual level, the institutional level, and the national level in terms of advocacy. What are the things that you can do to combat this moral injury? So let's start at the individual level, and I'm going to pivot a little bit, but still related in terms of contraception initiation. This is a 2016 study that was a survey of ED providers about their practices and their behaviors when it comes to initiating contraception in the ED. And in this study, they surveyed about 119 providers, and 86% preferred to refer to the outpatient setting for initiating contraception. And I get that. We are so busy. Your time in the department is so precious. And do you necessarily have the time to have this conversation with your patients, especially if it's not related to their chief complaint or integral in their complaint for that ER visit? You probably don't. 60% reported that they never provide prescriptions for non-emergency contraception. And the most interesting statistic of all to me is that 27% report feeling comfortable writing a new prescription for contraception. Only 27% felt comfortable. We're like the kings and queens of uncomfortable, right? Our job is so uncomfortable every day. We do high-risk procedures. We make decisions quickly that have major implications, yet only 27% of us feel comfortable writing that prescription? It's interesting, right? And so in thinking about these numbers, I would empower you to become more comfortable. This is something you can master. I know it. You've mastered bigger things. You can master contraception initiation in the emergency department in terms of what are the agents, what are the uses, what are the contraindications, how can I counsel my patients. I know you can master that and get comfortable. I feel quite confident in that. But let's say that's not you. Let's say that you've made that decision internally that that's not something I feel like I can master or have the time, or I don't want to take on that liability because I take on too much liability in my day-to-day life. That's okay. But instead, please look more into what your community resources are and how you refer patients to have that conversation as an outpatient instead of just saying, oh, you should follow up with an OBGYN if you want to have that talk. Give them actionable steps on how they do that if you're not the one doing it for them. Again, on an institutional level, in terms of contraception initiation, I want to talk about this study. It's an article in press right now coming out of Highland Hospital. They have a framework. I don't know if they're calling it contracepted or contracept ED, but either way, a framework on contraception initiation in the department. And I really liked this framework and so wanted to bring it up with you. And the way that they suggested that you ask your patients or talk to them about this is, do you plan to become pregnant in the next year? And I really like that as an opening statement to have this conversation. I think it feels non-judgmental. I think it opens up the table for conversation in a way that's not threatening and will allow you to learn more about your patient and potentially be there for them if they're ready to start contraception initiation. There are other goals and kind of framework in this study where, again, wanting their providers to understand the effective forms of contraception and their contraindications, like we discussed on the prior slide, facilitate those conversations, have a working knowledge of the placement and removal of the Nexplanon device with then kind of quality control competency measures to make sure that their providers were doing it safely and accurately, and offer that same day initiation of contraception for the patient's choice should they choose to proceed. Again, at the institutional level, it's critical that you know at your hospital, your clinical site, that should you have a patient come into the emergency department who needs reproductive care, what systems are in place to protect you? What is your hospital's policy? Can anyone raise their hands if they feel really confident if someone came in with a pregnancy-related complication and they would know how to handle it? That's great. I would say maybe about less than half-ish of the room, right? I didn't raise my hand, I don't. How is it that we can combat that in places where the legislature is more restrictive? So there has to be hospital policy. So you need to be asking, what is my policy to proceed? And if that policy doesn't exist, maybe you need to be the one to start that consortium of ED providers, of OBGYN providers, of hospital leadership, of your pharmacists to come up with that policy and that plan. And so that way, should that time arise, that you know you have that to fall back on. And then thirdly, from a legal perspective, what legal support, advice is your institution willing to provide for you should something happen and this proceed forward? Is your hospital going to cover your legal fees if this is related to abortion-related care? And that should be embedded within the policy and knowing exactly what your legal support is. Now, on a national level, multiple of our national physician groups have put out white paper, amicus briefs, policy statements, codes of ethics to discuss, these groups' opinions on our restrictions in reproductive care. As this landscape continues to change every single day with impending potential changes to misoprostol and mifepristone, there will be ongoing opportunities here. And so I would urge you to reach out to some of your national organizations to be a part of that force to continue to put our provider and our physician experience out there when it comes to these ongoing changes. The Physicians for Reproductive Health also has some resources. They have a leadership training academy. They offer counseling, like if you would like some advice on how to speak. If you want to be an advocate that's speaking, to the news or on some type of other level or social media or whatever else you're interested in, they can give you some speaking lessons. There are also some educational models and some direct physician support. And so I urge you to reach out to those resources on a national level. We'll have the need for it coming up, I feel confident.
And I just wanted to touch on, as you're all most likely physicians, and some residents, it's, as much as this kind of rocks your world in one way or the other, the medical student population is really felt this as well. And as medical students, we kind of look to you guys. You're kind of like our big superstar, and we kind of follow a lot of what goes on, especially on Twitter and the social media. So not just this, but all kinds of moral injury that's experienced. I think that especially with what's going on in that, if there's a way to kind of give students a way to work through some of the moral injury with you, for example, like having little student on your panel to give me a chance to talk and feel like I am contributing in some way.
You are.
ER people love to, be fixers. We don't like to just watch things happen. We want to fix stuff. So even though this can't be fixed, doing a little bit just kind of makes you feel better. So if anyone has the time or the heart to, grab a medical student and just kind of bring them along with you, it really does mean a lot, and I think it will help the future.
Agreed. Continuing with national advocacy, I just want to amplify and highlight some of the didactics that are here. If this is a topic that you are passionate about and want to learn more about. One of the first one listed is from yesterday, but please check out the slides. It was an amazing talk on self-induced abortions and some abortifacient toxidromes. And so please go look at those slides. They're excellent. The other two are today and tomorrow.
3 p.m.
And just to finish, when it comes to advocacy, I agree that the people that are really putting in the work when it comes to advocacy are heroes. You have the ability to be that person too, whether it's at that individual, institutional, or national level. And I hope we've come up with some ideas on things that maybe you can move forward with. Thank you.
Hello. I'm Amanda Deutsch. I am the current Wellness Fellow at Stanford and will soon be the Wellbeing Director at Jefferson. And bear with me, I have no slides, so I want you to look around in this room right now, if you don't mind, and realize that you made a choice to come to this talk. I know sometimes a wellness talk in general, people are like, okay, we've heard about wellness, we've heard about burnout, but I think this is relevant, obviously, as we've talked about and as we just saw. Every day there's something new that's giving us more moral injury. And how do we combat that? Our solutions, finding the data, is still hard. We've admitted that. But there is a great thing about emergency medicine is that we have some built-in ability to come back from this and to protect ourselves, and that's community. So already the people that are here, willing to be here right now, and then the unique ways in that we can create that, whether it's just joining SAEM, that's one huge way that we do that, but there's a lot of other little ones that I think sometimes we don't even acknowledge or think about and realize what that gives to us. So whether it's that you're a fellow and you get new co-fellows when you start, and you're able to have that group in a group me or a WhatsApp, that counts, right? You can start to build that. And I think even if you think back to your intern year and if you had an intern orientation, really taking that time to build the depth of some of those relationships so that you can fall back on those as well and really use that as you start to go through your career, you graduate residency, and you still, again, message out to those people when you're wondering, are they having this much waiting room problems? Are they feeling like their hands are tied and they don't know what to do as well? So those are some of the little ways that we can start to think about this. And then I think there's the unique ways that lovely to see that people build in, the peer-to-peer that you have in your residency if you create families and then you have an attending in those as well. The commensality groups, the evidence-based that you can go out to a meal with a few doctors, 6 to 8 or more, and you can have one topic that you're talking about that day. And so maybe it is, what do you do after that horrible day in June? And how do you go and talk about this so that med students, residents, everyone sees you're normal. It's okay to be scared by these ideas too. I think that's the huge part that all these communities offer to us, is that we can normalize the hard part of this and talk about what we're going through and not have to be stoic, not have to pretend it doesn't bother us, because it does. It makes every day hard when we all answered those polls that Vytas put up that we almost always, almost every shift, deal like with moral injury. And beyond that, there's other ways to really do this too. Commensality groups are great. The women in EM, having very specific groups too. How amazing are those groups to just offer camaraderie and be able to talk to someone about something a little bit different, because there we are experiencing it different than everyone else. The idea that you can have, we've started debriefing groups after traumatic deaths. And really, we have a grief counselor for those. And I think there's a lot of groups out there that we can be using and finding extra resources, because I think that's the hard part. Our solutions right now are we have to find them, we have to create them, but how do we start to protect ourselves a little bit more in these amazing communities we have? And so we were really excited to find that grief counselors want to talk to the trauma and emergency doctors and the techs and the social works and the pharmacist, everyone on our team that's having to deal with these hard things, and are opening up that we can have events to talk to people and really be able to have this moment to choose if you want to go onto the Zoom, because that's how we've done them in our institution right now, so that anyone that has that hour free, that one day a month that we've set it up, can go and just talk about any topic. And it's, again, safe spaces, but to be able to talk about whatever you've gone through. And I think that's one of the most unique things about emergency medicine in general. We have this built-in community, even if you're not part of one of these that I've mentioned, but when you go to the emergency department, you are not alone. And sometimes it still might feel that you are, and that's okay. And I want you to understand that I'm not saying there's not hard moments and that I have no idea what anyone's going through. But there is a built-in community the moment you step into an emergency department. And maybe it's that you're just seeing your charge nurse and you're able to say, I've had a really rough day. I may not be my best on shift today. I'm already in a mood. And you've just acknowledged another human, and at least you've gotten that off your back. And I definitely do that, by the way. So sorry to my future chair that's here and now knows that I will let it be known if I'm having a rough day. But it's being able to go in and have those moments and acknowledge the people that you work with and see them, just saying, that was awesome. Just thank you for how kind you were to the patient today. Like, that just reminded me too that I need to take a step back and remember these are people we're helping. Because it's hard when we face this every shift, when we are out in the waiting room and patients are mad that they're still sitting there. And you're like, I'm mad too. Like, I'm mad for you, and I wish I could help you in more ways. So I know I have both the negative and a positive tone on this, because I think we have an awesome job in that we have these communities and we can continue to build more. And I hope that we do. I hope that you have retreats for your residents and your fellows and your faculty so that you can remind each other that you have these amazing communities and you can come up with solutions together of what can we do right now. I'm not saying that we're going to change this all and take away moral injury, but I'm hoping that together we can try to have one thing that works at your shop for your group, because it's not a one-size-fits-all, as we know. It's different at each place, but we have this amazing opportunity. And that being said, if anyone has ideas that I've not brought up, book clubs, I know I did that in residency, a fantasy book club that we just loved getting to talk to each other about something that was not emergency medicine. I would love for people to share if they have any ideas. Thank you, LA.
Hello. Okay. I'm Megan Hunt from Wake Forest. So I think the biggest part about community is making a space where you're also not going to talk about work, like you said, fantasy book club. And I think that's a key point, especially when I was a student and when I was a resident, and it was like all I could think of because I had 80 hours a week. You're in the hospital. Like, what else are you going to talk about? As a medical director, people approach me now, and their first thing when they see me is like, oh, I've got a thing I want to talk to you about. And I was like, I bet it's not your kids. Is to just accept that that's a really important part of us. We aren't just our job. And I think that's a huge piece of feeling better.
I really appreciate that perspective, because I think one of the things we wanted to get at here is that we've been portrayed as superheroes trying to just fix all of these issues, right? And the reality is, just like you, I'm a human being who has to deal with a lot of crap in a very inefficient place, and we have to just acknowledge that. Part of the solution for moral injury is the acknowledgement that we are betraying ourselves in order to do the thing that we're expected to do. That's one thing. And then you can be kind to yourself and practice self-compassion, but the other part that's needed is also the acknowledgement from the community, from the institution. And that's harder. I can't ask an institution to say, like, yeah, we are causing you burnout, even though the institution knows this, right? It is designed to do that because we are workers. And so what I'm hearing all of in our conversation here is that we can create that community more than just as a community of practice, but also to create a voice, to understand that we have a choice here. We can either just continue dealing with all the crap that we deal with, or we can use it to advocate. There's a lot of like social EM people here, a lot of advocates in this room, and you don't necessarily have to be in social EM to truly believe that or to do things. I think what you've heard here in this group is that in your own way, you can show up the next shift and manage a lot of these morally distressing things that we deal with. And we're hoping to also highlight like current events, because it's not just like the burnout that we talk about, it's real things, right? Like even prescribing things that you're not allowed to do anymore. This is not what we practiced initially, and yet we have to now adapt to that. And so hopefully what we've shown you here is that we have a community amongst ourselves here, right? SAEM, education research, right? We can expand that. And also do better, and beyond just like you're right, not just work stuff, but talking about family, talking about the other things that are important in us. Great point, thank you for that. Any other thoughts?
I appreciate everything everybody said. I have a question, or maybe it's a meta question, but we're talking about moral injury, but if you think about medical education today, where do we actually learn about morality? Is it about moral formation? Even our residency programs, do we do that? And I say that because if we think medicine is a moral practice and that we're finding ourselves a little bit activated and agitated and we want to be advocates, then where is that moment for moral formation that ever occurs in our training? Or is it just a technical craft that we are learning? And that then when we talk about burnout, we are pathologized as individuals who don't have that center. I say that because I think it has to go way upstream. I really appreciate the medical student who came up, the resident came up and said, the medical student came up and said this, but even in your training, how much time is it spent on, actually we have to have moral practice. Let's talk about the morality of medicine, right? And the fact today that medicine is not becoming a moral practice. So that's my only comment. I think we face moral injury, we'll face more of that notion because we have not thought about this as a moral practice, and we continue to ignore that with a lot of our training systems. And the last comment, I'll say that. So I'm at MCW, we are having another redesign of our medical curriculum with this specific intention that our medical curriculum has to have character formation at its core. If it does not, then we're not going to be allowed to have, we're not going to create the workforce for tomorrow.
I like that a lot. Autonomy, belonging, competence, right? So if you can't do the job that you're expected to do, no autonomy, then that erodes into really what you're getting at is finding meaning in our work, right? The sense of belonging is the community that we're talking about. And the third part is competence. If we're not training the right things that we're supposed to be, we're expected to do, then also that erodes into finding meaning. I see you, Dr. Khan. I'm going to go here first.
My name is Brianne Jacobs. I'm from George Washington. I've actually written about moral injury and distress with Wendy Dean, who's the pioneer from psychiatry from moral injury and moral distress. And just two comments that I didn't see. Just the ICU nurses and nursing literature has done a ton on moral distress and ways that nurses have coped with it, because it's been, yes. And specific things is to take on to his point was designing more in the curriculum for our trainees about what they're going to face when they go into the ICUs and on those rotations, and now even what they're going to be seeing in the ER with boarding and waiting room medicine. And I think that there's a real need for more formal training within the emergency medicine curriculum on moral injury, and not basically just on ethics and a lot of the things that are going on. So that's one point. And then the second point, to the gentleman who asked, we don't know how to study this. Well, there is actually a moral injury symptom scale. It's a Likert scale that's been adapted from the military, that I've had other specialties that are writing about and have conducted among their institutions. Pediatrics was the one study that was sent to me. We need to do that within emergency medicine. You know, I would love to see an emergency medicine multi-institution go out. Go and send that out, and we can definitely, and then we can show the other people that don't, I guess, as viscerally feel it as much as we do, that it is a problem, and hopefully get some funding behind it to support a lot of what we're saying. Thank you.
Thank you. I really appreciate that perspective because, again, education and research, SAEM, I think what you're also getting at is this. We're trying to build the ship that gets us to Mars while also trying to figure out how to take care of each other. And hopefully, while we're doing that, we can have people like you who's really passionate about this and do the research. They can also help us kind of advance this better.
I just want to make a small comment on some of the topics that we've been looking at. It occurs to me that they're kind of in two buckets. And one is, you know, things that we cannot help. Horrible things happen with our patients. We absorb their pain. But then the other is like the system not working and us trying to make up for it. And you know, I've never, for example, heard firefighters talk about what they should do if they're not supplied like a firefighting like outfit that will protect them from the fire, right? Like, how can we band together with each other and make each other feel better as we like walk into the fire? Like, it doesn't make sense to me that we keep, like, it's almost a learned helplessness that we keep saying like, oh, okay, now you're gonna have me examine patients in a chair. All right, that's okay. You're not going to give me PPE. Okay, that's okay. You're not going to give me a place to admit my patients when they need admission. Like, or for them to follow up if they need follow-up care. At what point do we stop saying, like, let's band together as a community and say, like, we need to band together as a union or have some sort of collective bargaining within a society, like either ACEP or SAEM, and put a stop to it. Like that's why all of our studies are from nursing, right? Or military. Like those are institutions that have some form of collective bargaining, and we just don't. And we keep saying like, this is okay, and coming up with patches. I think like whenever engineers have a system that's broken, they just like break it down and start over. And all we keep doing is patching it and patching it and patching it. And it's gonna collapse under the weight of our patches, I think, eventually. Sorry, I set off something.
No, actually, I am in.
I think we agree with you.
I'm in complete agreement. You know, my personal spin on this is that we have let administration and we have let the healthcare administration people, and we've let all the middle managers take advantage of our calling and our professionalism and our dedication to our patients, and let everything else burn down. So I agree that we do need to look at ways to protect ourselves and our patients, but I also believe that everything that we advocate for has to come through a patient lens, because nobody cares when you advocate for yourself. If we are keeping the focus on the patients and advocating for our patients in ways that also benefit us as individuals, as professionals, as a group profession, then we can make some headway.
And with that, I understand that we're 5 minutes over, and you're morally distressing that you have to go to another talk. Thank you so much. We really appreciate it. Please give them a hand of applause.
Thank you, everyone, for coming and contributing to this discussion.